Right. Think about this. A child playing, maybe trips, falls onto their arm. What do you think is the most common elbow bone they break? Well, you might be surprised. It's actually not the joint itself, but the bit just above it. We're talking about supracondylar fractures, and they are, well, incredibly common. They make up something like, what, 60%? A huge chunk of all kids' elbow injuries, and you tend to see them most between, say, 5 and 8 years old, often just from everyday stuff. Interestingly, you see more of them at weekends or during the summer holidays, too. So today we're doing a proper deep dive into these really common childhood injuries. Our mission really is to unpack what a supracondylar fracture actually is, understand all the nuances, look at how we diagnose and classify them, and then critically examine the different ways we manage them. That ranges from, just immobilization right through to some pretty complex surgery, and crucially what practitioners like you need to know about potential problems, the complications, and what the long-term outlook is for these young patients. We'll be focusing a lot on just how vital meticulous assessment and properly tailored care are for getting the best results. And to guide us through all this complexity, we're incredibly lucky to have a leading expert with us today, someone with just vast clinical experience and research background in pediatric orthopedics. Welcome.
Thank you very much for having me. It's great to be here to talk about what is actually a really important topic in pediatric trauma. Clinicians see these surprisingly often.
They really do. So just to kick us off, from your perspective, what's the absolute single most crucial thing for any clinician to grasp when they first encounter a child with a suspected supracondylar fracture?
Right. The absolute non-negotiable priority has to be a thorough neurovascular assessment. You simply must know the status of the nerves and the blood vessels before you do anything else, before any manipulation. That gives you your baseline and dictates how urgently you need to act.
Okay, baseline and urgency. Got it. And if you had to quickly sum up the typical way these happen, the mechanism that causes most of them.
Overwhelmingly, it's a fall onto an outstretched hand. Simple as that. The elbow gets forced into hyperextension, extreme hyperextension. And that puts immense stress right on that naturally weak spot in the humerus we were talking about, just above the joint, leading to that characteristic break.
Right, that classic Fuchs injury. Okay. And finally, before we really dive in, is there one common misconception about these fractures you often come across, something people frequently get wrong?
Yes, a common one is thinking that every supracondylar fracture will have a really obviously deformed elbow, a big bend in the arm. But actually, many of them, especially the less severe types, can look quite subtle initially, which is precisely why that thorough clinical check and good x-rays are so vital. They can be, well, quite deceptive sometimes.
That's a really important point. Don't rely just on seeing a massive deformity. Okay, vital insights. Let's properly start our deep dive then. Understanding the basics. When we say supracondylar fracture anatomically, what exactly are we describing?
Okay, so fundamentally, it's a break in the distal humerus, the lower end of the upper arm bone. Specifically, it's in that thin, flared part just above the actual elbow joint structures, the condyles, and critically, it's above the growth plate, the physis. That location is key. It defines the fracture, dictates its behavior, and really informs how we manage it differently from other elbow injuries. The bone in that specific area, it thins out quite significantly where the olecranon fossa is. That's the hollow at the back that the pointy bit of the elbow, the olecranon, slots into when you straighten your arm. This thinning creates a natural weak point, almost like a pre-designed fault line, making it prone to breaking under stress.
So a specific weak spot, naturally prone to fracture. You mentioned how common they are. Just how prevalent are we talking, beyond just elbow injuries?
Yeah. Oh, absolutely. They are, without a doubt, the most common elbow fracture in children, no question. But it goes further. They make up a really significant percentage, about 18% of all fractures seen in children, right across the body. And while any child can get one, there's definitely a peak incidence in that very active 5 to 8-year-old age group. And interestingly, it's often the non-dominant arm, probably because that's the one they instinctively stick out to break a fall, you see.
That makes perfect sense, using the non-dominant arm instinctively. And speaking of falls, let's really unpack the mechanisms. You said the extension type accounts for, what, 95–98% of them. Can you walk us through the mechanics of that specific injury?
Yes, certainly. The classic story is the fall onto the outstretched hand, the phoshech, forcing the elbow into hyperextension. What happens mechanically is the olecranon process, that bony tip of the ulna at the back of the elbow, slams forcefully into the olecranon fossa in the humerus. Now, normally that fossa accommodates the olecranon, but when the elbow is forced beyond its normal straight position, that impact generates huge stress right at that thin, weak supracondylar area. This stress causes the anterior cortex, the front wall of the humerus, to fail under tension. It essentially snaps the bone right there.
So it's a direct result of the elbow being bent backwards too far. What about the much rarer flexion-type fractures then? How do they happen?
Flexion types are, yes, much less common, less than 5% typically. They happen from a direct blow or fall onto a banked elbow. So the force comes from a different direction. The mechanics are different too. Instead of the distal fragment, the bit below the break, being pushed backwards, it's actually driven forwards anteriorly by the impact.
And why children? Why are they particularly susceptible to the common extension type? Is there something about their growing bodies?
Yes, there is. And it's a really crucial factor. Children naturally have more ligamentous laxity around their elbows compared to adults. Their ligaments are just generally more flexible, more stretchy, which allows for a greater degree of hyperextension. So you combine that increased flexibility with their, well, active lifestyles, frequent falls, maybe a bit of clumsiness, and it directly contributes to this higher rate of extension-type fractures. Their anatomy, built for growth, ironically creates this specific vulnerability.
Fascinating interplay between anatomy and activity. You mentioned the growth plate and other landmarks earlier. Can you expand a bit on the key anatomical structures we need to keep in mind here and why understanding them is so critical, especially in kids?
Of course. So beyond the main shaft of the humerus, you've got the medial and lateral columns distally. These are like the pillars supporting the joint. Then the joint surfaces themselves. The trochleus, which is like a stool and articulates with the ulna, and the capitellum, a rounded knob that articulates with the radius. And the epicondyles, those bony bumps you can feel on either side of your elbow, all key landmarks. And as I said, that thinned out area at the olecranon fossa is the inherent weak spot. But specifically for children, the absolute key for reading x-rays correctly is understanding the predictable sequence of ossification centers appearing around the elbow. These are areas where cartilage is turning into bone, and they appear at fairly predictable ages. You might remember the mnemonic Crido or something similar. So the capitellum appears around age 1, radial head around 4, medial epicondyle around 6, trochleus at 8, olecranon at 10, and the lateral epicondyle around 12, roughly speaking. Knowing this sequence is vital. It stops you mistaking a normal growth plate, which looks like a gap on X-ray, for a fracture line.
Or helps you spot when a growth plate injury, a physial separation, might be mimicking a dislocation, especially in very young children, before much bone is formed. Getting that right prevents misdiagnosis and leads to the right treatment. It's a common pitfall if you're not used to looking at children's elbow x-rays.
That detail on ossification centers is absolutely critical, isn't it? Really highlights the unique challenge of pediatric x-rays. Knowing that timeline is your safety net against calling a normal growth plate a fracture. Right. So the child arrives, you suspect this injury. What are the common signs and symptoms you're looking for, and how do you conduct that vital initial assessment?
Okay, so typically the child will present with, well, significant pain, often quite severe, and marked swelling around the elbow that can come on very, very quickly, quite dramatically sometimes. They'll also have a really restricted range of motion. Often they'll hold the arm very still, refusing to move it at all. If it's a significantly displaced extension fracture, you might see that characteristic S-shaped deformity of the arm. It's quite a distinct visual clue when it's present. And interestingly, in very young children, because of the deformity and swelling, it can sometimes look a bit like an elbow dislocation. It's also worth remembering a child who's very quiet, withdrawn, and obviously in pain can be just as concerning as one who's screaming.
Okay, pain, rapid swelling, limited movement, maybe that S-shape, all clear signals. You stressed the neurovascular exam earlier. Can you walk us through how you do that and remind us why it has to be done before any reduction attempt?
Absolutely paramount. Doing it before any manipulation, any attempt to straighten the arm, is crucial. It gives you that baseline. It means if anything changes later, if it was potentially caused by the intervention, the reduction itself, what we call an iatrogenic injury. So for the nerve assessment, we systematically check the median, radial, and ulnar nerves. We pay particular attention to the anterior interosseous nerve, the AIN. That's a branch of the median nerve, and it's the one most commonly injured in these extension-type fractures. The simple test for the AIN is asking the child to make an AOK sign with their thumb and index finger. That tests the specific muscles supplied by the AM. For the radial nerve, you're looking for wrist and finger extension, show me your stop sign. For the ulnar nerve, spreading the fingers apart against resistance. It's really important, by the way, to reassure parents that most nerve injuries with these fractures, these nerve palsies, are temporary neuropraxias, usually from bruising or stretching. They nearly always resolve on their own, typically within, say, 2 to 3 months. So they do need careful follow-up. Then for the vascular assessment, we meticulously check the pulses. Radial pulse at the wrist, primarily.
Careful palpation is the first step, but if it's weak or absent, or if you're unsure, a handheld Doppler ultrasound is invaluable for detecting blood flow. We also look at the distal perfusion. Is the hand warm? Is it pink? What's the capillary refill time? Press on a fingernail. It should pink up again in less than 2 seconds.
And that leads perfectly to that really critical distinction you mentioned earlier, the pulseless pink versus the pulseless pale hand. That sounds like it completely changes the game in terms of urgency. Can you explain that vital difference?
Yes, this distinction is absolutely crucial. It dictates everything about the immediate next steps. A pulseless pink hand means that even though you can't feel a radial pulse, perhaps not even detect it with a Doppler, the hand itself is still warm. It looks pink, and the capillary refill is normal, brisk. This tells you that the collateral blood vessels are on the elbow, the backup supply are doing their job in maintaining adequate perfusion to the hand. Now, this still requires urgent orthopedic assessment and careful monitoring, definitely same-day surgery usually, but it's generally not an immediate limb-threatening catastrophe. Often the pulse returns after the fracture is reduced and stabilized. But in stark contrast, a pulseless, pale, cold hand, well, that's a different story entirely. It signifies true ischemia. The hand looks white or mottled. It feels cool or cold compared to the other side, and the capillary refill is sluggish, delayed, maybe more than 2 or 3 seconds. This is a massive red flag. It means severe, ongoing lack of blood supply. It's a true surgical emergency. You need immediate intervention, usually reduction in pinning and potentially vascular exploration, to restore blood flow and prevent permanent muscle and nerve damage like that devastating Volkmann's contracture. So, to put it simply for everyone listening, pink and pulseless needs urgent attention. Pale and pulseless is a dire emergency. Get moving fast.
That's incredibly clear and highlights the immediate stakes involved. So apart from that pulseless pale hand, what other urgent clinical signs should make someone immediately pick up the phone for an orthopedic review in the emergency department?
Okay, beyond the critical pale, pulseless hand, there are several other definite red flags. The absence of a radial pulse, even if the hand is pink, still warrants prompt orthopedic consultation and likely urgent surgery. Any sign of hand ischemia, like that pale, cold appearance we just discussed, is an emergency. Severe swelling, particularly if it involves the forearm and feels very tense, is a major worry because it raises the specter of compartment syndrome. Another really critical sign is skin puckering or significant bruising right in the crease of the elbow, the antecubital fossa. This is sometimes called the pucker sign or brachialis sign. It suggests the sharp end of the proximal fracture fragment, the bit attached to the upper arm, has actually poked through the brachialis muscle. This signifies a high-energy injury and a much higher risk of the brachial artery or median nerve being trapped or injured. If you see that sign, think high risk. And of course, any open fracture where the skin is broken needs immediate attention, as does any neurological deficit, even if it seems minor at first glance. All require urgent orthopedic input.
It sounds like a really sharp clinical eye is absolutely essential for spotting these details. And how important is it to look beyond the elbow itself for other injuries?
Oh, absolutely crucial. You must always assess for associated injuries, especially in the same limb, so the forearm or the wrist on the same side. Finding another fracture, like a distal radius fracture, significantly impacts the overall swelling, makes the assessment trickier, and definitely influences the management plan and the urgency. A floating elbow, that's the term for having both a supracondylar fracture and fractures in the forearm or wrist on the same side, is a particularly serious situation. It significantly increases the risk of compartment syndrome due to all the bleeding and swelling in a confined space. These usually require very timely surgical stabilization of both injury sites to reduce that risk. So yes, always examine the whole limb, elbow to fingertips.
Right, look at the whole picture. Okay, so once you've got that clear clinical assessment, what's next? How do we actually diagnose and classify these using imaging?
The standard approach is plain X-rays. You need good quality anteroposterior, AP, and lateral views. And it's important to request X-rays of the distal humerus, not just elbow. You need to see enough of the humeral shaft above the fracture to properly assess the alignment and displacement. For children who come in with a very obvious severe deformity, it's really important to splint them first, usually in about 30 degrees of flexion, before sending them for X-rays. This helps manage their pain, but also crucially prevents further damage to nerves or blood vessels during positioning for the images.
Makes sense. So the X-ray isn't just about spotting the break, it's about reading all those subtle signs you mentioned. What are the key things you're looking for on that film that might not jump out at first glance?
Exactly. Beyond just seeing the fracture line, especially in less displaced cases, there are critical radiographic signs. Firstly, fat pad signs. On a good lateral X-ray, you might see the anterior fat pad pushed forwards, looking like a sale sign, Or more significantly, you might see the posterior fat pad becoming visible. Normally, the posterior fat pad is tucked away in the olecranon fossa and shouldn't be seen. If you can see it, it strongly suggests bleeding or fluid within the joint, which usually means an underlying fracture even if you can't clearly see the line itself. The posterior fat pad sign is a very sensitive indicator of an intra-articular effusion. Secondly, the anterior humeral line, AHL. You draw a line down the front edge of the humerus on the lateral view. Normally, this line should pass right through the middle third of the capitellum. In an extension-type fracture, where the distal fragment is displaced backwards, this line will pass anterior to the capitellum, or might miss it altogether. It's a very reliable sign of posterior displacement. Thirdly, Bowman's angle. This is measured on the AP view.
It's the angle between a line down the long axis of the humerus and a line across the growth plate of the capitellum. You compare it to the uninjured side. A difference of more than, say, 5 to 10 degrees indicates a coronal plane deformity, a tilt sideways. And this is critical because, as we'll discuss, these varus or valgus deformities do not remodel well in children. And lastly, the radiocapitellar line. Draw a line through the middle of the radius shaft. It should point directly at the capitellum on every single view, no matter how the elbow is positioned. If it doesn't, it means there's likely an associated dislocation of the radial head, or perhaps a radial neck fracture. Helps rule out other injuries.
That's a huge amount of detail packed into those x-rays, really emphasizing the need for careful interpretation. So once you've assessed these features, how do you apply the Gartland classification? You said that's the cornerstone for treatment decisions.
It really is. The Gartland classification applies specifically to the common extension-type fractures. Type UN is non-displaced or minimally displaced, usually less than 2 millimeters shift. The cortex, the outer shell of the bone, is intact on both sides, and that anterior humeral line is normal, passing through the middle of the capitellum. These can be subtle, often suspected mainly because of those fat pad signs, least severe. Type 2 fractures are angulated, tilted backwards usually, but the posterior cortex, the back wall of the bone, is still intact. It acts like a hinge. The AHL will pass anterior to the capitellum. These type 2s can also have some sideways shift, translation, or rotation. This led to the Wilkins modification. Type IIA is pure extension angulation, while type IIB has that added rotational component, which makes it much more unstable and usually pushes you toward surgery. Type 3 fractures are completely displaced. There's no contact at all between the broken bone ends. The distal fragment is typically shifted posteriorly and often medially or laterally as well. These are high-energy injuries with the greatest risk of nerve or vessel damage because everything's been disrupted. And then there's type 4. This is a relatively newer category. It describes fractures that are unstable in both flexion and extension due to complete disruption of the periosteum, the membrane covering the bone. They are multidirectionally unstable. This instability is often only fully appreciated during an examination under anesthesia right before surgery because the limb is just completely floppy at the fracture site.
Okay, so Gartland the first, third, and free, with increasing severity and instability. It sounds like x-rays are the workhorse, but what about more advanced imaging? When might you need a CT scan or maybe ultrasound?
Plain x-rays are definitely sufficient for most cases, but advanced imaging does have a role in specific situations. CT scans, especially with 3D reconstructions, can be incredibly helpful for really complex fractures. Say, if there's significant comminution, the bone is shattered into multiple fragments, or if you strongly suspect the fracture line extends right into the joint surface, which can be hard to see clearly on x-ray. The CT gives you that detailed map, which is invaluable for planning surgery accurately, particularly for those tricky type IVs or ones with intra-articular extension. Sometimes, if a CT isn't readily available, you might use traction radiographs in the operating theater. Gently pulling on the arm under anesthesia can sometimes pull the fragments apart slightly, giving a clearer view of the fracture pattern. Ultrasound can be a useful extra tool, especially for spotting those subtle type I fractures in very young children where the bones aren't fully ossified yet. It's good for visualizing joint effusions of those fat pads. MRI, however, is very rarely used in the acute setting for these fractures. It takes too long, usually requires sedation or anesthesia for a child, and doesn't typically add much urgent information beyond what x-rays and CT can provide for managing the immediate trauma.
Right, so CT for complex planning, ultrasound for subtle cases, but x-ray remains king. Okay, so we have the diagnosis, we have the classification. Let's move into management. What are the main goals when treating these, and how do you start deciding between simply immobilizing it versus needing surgical precision?
The goals are pretty clear. First and foremost, effective pain relief for the child. Then, promoting good bone healing in the right position, facilitating a rapid return to full elbow movement and function. And crucially, preventing complications, both early ones like nerve injury or compartment syndrome, and later ones like stiffness or deformity. The decision between non-operative and operative treatment hinges almost entirely on that Gartland classification, the degree of displacement and instability, and absolutely critically, the neurovascular status of the hand. It's always a risk-benefit calculation tailored to the individual child and their specific fracture pattern.
Let's start with non-operative then. Which fractures are suitable for this, and what does it typically involve?
Okay, non-operative management is really only for the truly non-displaced Gartland type I fractures, and potentially for very carefully selected minimally displaced type IIA fractures, those with just simple angulation, where that posterior hinge is definitely intact and stable and there's no rotation. The method is straightforward. Immobilization in an above-elbow back slab, usually made of plaster or fiberglass. The elbow is typically flexed to about 90 degrees, and the arm supported in a collar and cuff sling or broad arm sling. This immobilization is usually kept on for about 3 weeks, enough time for the bone to get sticky and start healing. A really practical point for anyone applying these splints: make sure the back slab is long enough. It needs to go high up the arm, close to the armpit, and extend right down to the wrist or even the knuckles. And it needs to be solid, not flimsy. A poorly applied cast just won't hold the reduction and risks the fracture slipping. Follow-up for a simple Gartland type I is usually straightforward too, often just a GP checkup after 3 weeks when the cast comes off. Repeat x-rays usually aren't needed unless there's a specific concern. For type 2 fractures managed non-operatively, however, you typically want them seen back in a fracture clinic within about a week, often with a check x-ray, just to make absolutely sure the position hasn't changed as the initial swelling settles. They are inherently a bit less stable than type is.
Okay, fairly simple for type I, but when would you look at a type IIA, even one that seems minimally displaced, and say, no, this needs surgery? What are the contraindications for non-operative treatment there?
All right, even for a type IIA, there are definite times when non-operative management isn't appropriate. If there's significant comminution, particularly crushing of the medial column, that indicates instability that a cast alone likely won't control. Similarly, if there's significant posterior displacement, even if hinged, or if there's excessive swelling around the elbow that raises concerns about vascular compromise or impending compartment syndrome if you try to hold it flexed in tight cast. Also critically, if you find you need to flex the elbow beyond 90 degrees to keep the fracture reduced in the cast, that's generally a contraindication. Excessive flexion can kink the brachial artery or compress nerves and increase compartment pressure. That pushes you towards pinning it surgically. And one really important pitfall to avoid: sometimes what looks like a type I on x-ray actually has some subtle medial impaction or crushing. If you miss that and just cast it, it can lead to a cubitus varus, or gunstock, deformity developing as it heals. And that varus deformity, that sideways tilt, will not remodel with growth and often needs corrective surgery later purely for cosmetic reasons, or sometimes function.
So careful scrutiny of that medial side on the AP x-ray is vital, even in seemingly simple fractures.
So paying close attention to that medial column integrity is key. Okay, so if non-operative isn't suitable, we're looking at surgery. When is operative management indicated, and what's the sort of timescale or urgency involved?
The timing of surgery is absolutely dictated by the clinical picture, especially the neurovascular status. We tend to think in terms of urgency levels. Urgent, meaning surgery should happen the same day, usually within 6-12 hours if possible. This applies to that pulseless pink hand we talked about. Also, any sensory nerve deficit, severe swelling, especially with that brachialis sign or skin pucker, and the floating elbow scenario. The supracondylar plus forearm fracture needs timely pinning of both to minimize compartment syndrome risk. Gartland type IIB 3 and 4V fractures generally fall into this urgent category too because of their instability. Emergent, meaning surgery needs to happen right now, within a few hours at most. This is reserved for the pulseless, pale, cold hand. That's a true vascular emergency. Delay risks limb loss. And then there's a situation where you need emergent vascular exploration alongside the pinning, CRPP. This happens if blood flow is lost after you've reduced and pinned the fracture. If the hand suddenly goes pale and pulseless on the operating table after you've put the wires in, you have to consider taking them out immediately and potentially having a vascular surgeon explore the artery. It's rare, but critical to recognize.
It's so clear how central that vascular status is to every decision. So for the displaced fractures needing surgery, what's considered the gold standard technique, and can you talk us through how you actually manipulate the bones back into place, the reduction maneuvers?
The gold standard for most displaced fractures is closed reduction and percutaneous pinning, or CRPP. Closed, meaning we don't make a big cut. Percutaneous, meaning the pins go through the skin. It's minimally invasive, but provides stable fixation. The reduction itself involves specific maneuvers under anesthesia, often using X-ray guidance, what we call fluoroscopy. First, you apply steady, inline traction to the arm, maybe for a couple of minutes. This overcomes muscle spasm, disimpacts the fragments, and helps restore length. Then you correct any sideways mediolateral shift and any rotation. Finally, you correct the main displacement in the sagittal plane. For the common extension-type fracture, this usually involves flexing the elbow while applying gentle pressure forwards on the olecranon, the distal fragment, to push it back into place under the proximal fragment, correcting that posterior displacement. Sometimes hyperflexion is needed. For very unstable ones like type IVs, you might use a joystick technique, inserting a temporary K-wire into the distal fragment to use as a handle for more controlled manipulation. And specific forearm positioning can really help stabilize the reduction while you pin it. Pronating the forearm tends to tighten medial structures and help stabilize posteromedial displacements. Supinating it tightens the lateral side, helping with posterolateral displacements. These subtle techniques leverage the intact soft tissue hinges.
That's fascinating, using the forearm rotation to help stabilize the fracture. Real precision involved. Once it's reduced, how do you pin it? What are the options? And the pros and cons surgeons weigh up.
There are essentially two main configurations for the pins, the K-wires. Lateral pinning is very common. You insert 2 or sometimes 3 K-wires just from the lateral outer side of the elbow. The big advantage here is a much lower risk of injuring the ulnar nerve, which runs down the medial inner side. The risk is very low, maybe less than 0.5%. For lateral pins to be stable, they need to be well spread out where they enter the bone and ideally engage both the medial and lateral columns of the humerus further up, creating a stable construct. The alternative is crossed pinning. One pin goes in laterally and one goes in medially. Biomechanically, this configuration is stronger, especially against rotation or twisting forces. So it might be preferred if the fracture seems particularly unstable, especially if there's significant medial comminution or if lateral pins alone don't feel stable enough. The downside is the higher risk of injuring the ulnar nerve with that medial pin. The risk is quoted somewhere between 3% and 8%. To minimize this risk, experienced surgeons will often place the medial pin with the elbow held in extension, as this position moves the ulnar nerve slightly out of the way. And critically, many advocate for making a tiny incision, a mini open approach, for the medial pin, so you can directly see and protect the nerve, rather than just pushing the pin through the skin blind. Also vital is that the pins cross above the fracture site for maximum stability.
Right, so a trade-off between stability and nerve injury risk, with techniques to mitigate that. What happens immediately after pinning? Do you check the circulation again? And what if it hasn't improved or has worsened?
Absolutely. Reassessing the vascular status after reduction and pinning is a non-negotiable step. Check the pulse, check the Doppler, check the hand color, and capillary refill again. If perfusion isn't restored, or worse, if a previously present pulse disappears after pinning, you have to act fast. It might mean the artery is kinked, trapped, or even injured by the manipulation or a pin. In that situation, immediate vascular exploration, usually by a vascular or experienced orthopedic surgeon, is needed to find the problem and fix it. Removing the pins might be the first step if entrapment is suspected. You cannot leave a poorly perfused hand.
Okay, and what if you simply can't get the bones lined up with closed methods? Or if it's an open fracture to begin with, when do you have to proceed to an open reduction?
Yes, open reduction and percutaneous pinning becomes necessary in a few situations. Obviously, for all open fractures, where there's a wound communicating with the bone, you need to open it up, clean it out thoroughly, debridement, and then fix the fracture. It's also needed if closed reduction fails. Sometimes soft tissue, like the brachialis muscle, or even the brachial artery or median nerve, can get trapped between the bone ends, physically blocking reduction. You can pull and push all you like, but it won't go back into place until you surgically remove the blockage. And as we just discussed, it's required if you need to do a vascular exploration and repair. The most common surgical approach for open reduction is usually an anterior one coming in from the front of the elbow. This gives good access to those vital neurovascular structures and allows you to directly visualize and remove whatever is blocking the reduction before pinning it.
And just quickly, before surgery, what's the standard preoperative preparation?
Standard procedure is to keep the child nil orally. No food or drink once the decision for surgery is likely, in preparation for anesthesia. And for open fractures, it's absolutely crucial to check their tetanus immunization status and give a booster if needed because of the contamination risk. Basic antibiotics are usually given too.
Right, got it. Now, let's shift focus slightly to the potential pitfalls and long-term picture. What are the major complications we need to be aware of, starting with vascular injury, which seems like a constant theme?
It is a constant theme, yes. Vascular injury is a major concern, especially with those high-energy Gartland third fractures. As we said, absent radial pulse is seen initially in maybe 7–20% of cases. The key remains that pulseless pink hand. If the hand stays well perfused after reduction, even without a palpable pulse, often careful observation is appropriate because the collateral circulation is sufficient. The pulse frequently returns over hours or days as swelling reduces. But, and it bears repeating, the pulseless pale white hand is the emergency. That needs immediate action to restore flow and prevent irreversible damage like Volkmann's ischemic contracture, that claw-like hand deformity from muscle death.
And the one everyone dreads, compartment syndrome. How does it actually present, and what happens if it's missed?
Compartment syndrome is, yes, probably the most feared acute complication in orthopedics, though thankfully rare with these fractures if managed appropriately. It's caused by swelling and bleeding within the tight fascial compartments of the forearm, increasing pressure to the point where it cuts off blood supply to the muscles and nerves within that compartment. It can be insidious, developing over hours. The classic signs are often called the P's, though pain is the most reliable early one. Pain out of proportion to the injury, pain on passive stretch of the fingers, paresthesia, numbness or tingling, pallor, though this is often a late sign, pulselessness, also late, and paralysis or muscle weakness. Crucially, the child might have increasing pain requiring more and more analgesia. The forearm might feel incredibly tense, hard like wood. If it's missed or untreated, the lack of oxygen leads to irreversible muscle death and nerve damage, resulting in that devastating Volkmann's ischemic contracture, leaving the child with a permanent, useless, clawed hand and forearm. Prompt diagnosis and emergency surgical decompression fasciotomy are vital. And remember, excessive elbow flexion in a cast can also cause it.
A truly devastating outcome. What about nerve injuries? You said most recover, but are there signs that might suggest a more serious nerve problem needing intervention?
Correct. Neuroapraxia, temporary nerve bruising, or stretch, is relatively common, seen in maybe 11–17% of cases. The AIN is most common in extension types. The ulnar nerve can be injured too, especially with flexion types or sometimes iatrogenically with medial pinning. The vast majority do recover spontaneously, usually starting within weeks and often fully recovered by 2–3 months. Reassurance is key here. However, alarm bells should ring if a nerve deficit appears or worsens after reduction in pinning. That strongly suggests the nerve might have become trapped in the fracture site or injured by a pin. That would warrant consideration for surgical exploration. Also, if there's absolutely no sign of recovery after, say, 3–6 months, particularly with complete palsy, then nerve exploration might be considered, though often continued observation is still preferred as recovery can sometimes be delayed.
Okay, so deterioration after reduction is the main red flag for nerve entrapment. Let's talk about healing in the wrong position, malunion and deformity. What's the most common issue there, and how does it impact the child long-term, especially considering what you said about remodeling potential?
The most common long-term deformity by far is cubitus varus. This is often called a gunstock deformity because the arm looks bent inwards at the elbow when held straight, resembling the stock of a rifle. It results from malunion, usually due to residual rotation or tilt in the coronal plane, sideways tilt, that wasn't perfectly corrected or held during healing. Often, it only becomes obvious weeks or months later when the child regains full extension. For the most part, it's primarily a cosmetic issue, but it can occasionally be linked to later problems, like tardy ulnar nerve palsy, developing years down the line due to nerve stretching, or sometimes subtle elbow instability. And this is the absolutely critical point about remodeling. While some angulation in the sagittal plane, flexion extension, can remodel quite well, especially in younger children, deformities in the coronal plane, or os valgus, and rotational deformities essentially do not remodel significantly. So if a child heals with a significant varus deformity, it's permanent unless corrected surgically later, usually with an operation called an osteotomy to re-break and realign the bone.
Less commonly, you can get cubitus valgus, where the arm bends outwards. This can also cause tardy ulnar nerve issues. And recurvatum or hyperextension deformity can occur, especially if type 2 or 3 fractures are managed non-operatively, and the sagittal alignment isn't perfect.
That lack of coronal plane remodeling is such a crucial take-home message. Precise reduction is key, not just for now, but for the future. What about stiffness? Is that a major long-term problem after these injuries, and is physiotherapy needed?
Elbow stiffness is actually very common immediately after the cast comes off. The elbow often feels very stiff and sore, and parents can get quite worried. But the good news is, children have an amazing capacity for regaining motion. The vast majority will regain full, or very near full, range of movement within about 6–12 months, just through normal use and play. Interestingly, and perhaps counterintuitively for some, Formal structured physiotherapy is generally not required or recommended for routine supracondylar fractures after cast removal. Current evidence doesn't really support it for improving final outcomes. Gentle encouragement of normal activity and allowing the child to gradually increase movement themselves seems to be just as, if not more, effective. Sometimes overly aggressive physiotherapy can even be counterproductive or cause more pain.
That's really interesting. Trust the child's natural recovery process. Are there any other, perhaps less common complications people should just have on their radar?
Yes, a few others worth mentioning. Pin site infection can occur, but it's usually superficial and responds well to pin removal and sometimes a short course of antibiotics. Deep infection is rare. Pin migration, where the K-wires shift position before the fracture is healed, is probably the most common pin-related nuisance. Sometimes they back out slightly and need trimming or early removal. And a rare but significant leak complication is avascular necrosis, AVN, of the trochlea. This means part of the trochlea loses its blood supply and can collapse, leading to a fishtail deformity on X-ray. This can cause pain, clicking, and restricted movement later on. It's uncommon, but important to know about.
Okay, so despite all these potential issues, what's the overall outlook? What's the general prognosis for kids with these fractures?
Despite the potential severity, the overall prognosis for pediatric supracondylar fractures is actually very good, provided they receive timely and appropriate management. The final outcome really depends on that initial Gartland grade, how well the fracture was reduced and stabilized, and whether any neurovascular complications were identified and managed effectively. Younger children do have more potential for remodeling minor residual angulation, but remember, that's mainly in the sagittal plane. Coronal plane and rotational alignment needs to be near perfect from the start for the best long-term cosmetic and functional result. But most children make an excellent recovery.
That's reassuring to hear. As we bring this deep dive to a close, what are the absolute key takeaways you'd want our listeners to remember about supracondylar fractures?
I think the main things are, firstly, recognize how common they are. You will see them. Secondly, the Gartland classification is your guide to treatment. Know it. Thirdly, that meticulous neurovascular assessment before and after any intervention is absolutely non-negotiable. Distinguish pink from pale. Fourthly, be vigilant for compartment syndrome pain out of proportion is the key early sign. And finally, aim for anatomical reduction, especially correcting rotation and coronal tilt, because those don't remodel well. Get those right, manage the complications promptly, and most kids will do extremely well.
Excellent summary. It's clear that understanding these injuries with such detail is vital. What's the broader relevance here for healthcare professionals, maybe even beyond orthopedics?
Well, I think it highlights the unique aspects of treating children's injuries, the importance of understanding growth plates, remodeling potential, and the specific injury patterns they get. But more broadly, it's a powerful example of how meticulous assessment, accurate diagnosis, precise intervention, and vigilant monitoring are crucial for achieving good outcomes in any acute injury situation. It underscores the need for a systematic approach and the potentially devastating consequences of missing subtle but critical signs. It's really about giving that child the best possible chance to recover fully and get back to just being a kid without long-term problems.
A perfect encapsulation. And to leave our listeners with a final thought to mull over, given how even subtle rotational or sideways deformities in these fractures can have significant long-term cosmetic and functional consequences, what broader lesson can we take about the critical importance of anatomical alignment across all musculoskeletal injuries, perhaps even ones we might initially dismiss as minor?
That's a really insightful question. I think the lesson is that anatomical restoration matters, perhaps more than we sometimes appreciate. What looks good enough functionally in the short term might sow the seeds for problems like arthritis, instability, or nerve issues years later if the underlying mechanics are altered by malalignment. It really reinforces the principle that, especially in growing bodies, but even in adults, striving for the most accurate anatomical reduction possible, respecting the body's normal structure, should always be a primary goal in fracture management. It's about optimizing long-term function and preventing future complications, not just getting the bone to heal. Precision matters.
Precision matters, a powerful and fundamental point to end on. Thank you so much for sharing your expertise today. It's been incredibly insightful. And if you, our listeners, found this deep dive valuable, please do take a moment to rate and share the show with colleagues who might also benefit. Thank you for joining us.